unsatisfactory. So excellent remarks were received from most of the students, comprising of 60 to 70%. So this is the blueprint of the Grand OSCE circuit, which we followed on the day of exam. If you look over here, it is comprised of total 18 stations. As I already mentioned, that 18 stations were there, 6 stations allocated to each subject, that is medicine, surgery, and pediatrics, and kept a few rest stations in between to cover the increased number of students as well. Thank you. Questions, please.
Any question from the audience?
Okay, there were several benefits if we talk about the Grand OSCE as compared to the OSCE or the traditional OSCE which we were having over the past decade. We can say, as far as the logistics were concerned, definitely there was a benefit of logistics. There was benefit of the manpower, mental trauma, exertion. There were different benefits which we can say that yes, there was less mental exertion, manpower was reduced, and it was well executed, and also transparency was maintained as well. And it was purely on the clinical skills. When the number of students were more and we were conducting OSCE on individual days for each subject, we were keeping fillers in between. So the purpose of assessing the clinical skills was diminishing as the number of students was increasing, and we were just keeping to accommodate more students in between. So while having this Grand OSCE, it was purely assessing the clinical skills, both the hard and the soft skills as well.
All the areas of subject in, because you have got the only few portion, and like you are having included medicine, surgery, and all the other subjects. So how will you justify that this subject is almost covered or not?
So I would not say that we covered almost everything by conducting this Grand OSCE, but yes, we definitely covered most of the subjects and most of the areas which we could cover. We had interdepartmental meetings, and we came up with different skills or different areas which could be covered in all the subjects. Like there are different skills which are common in all the departments and the specialties, like passing NG, passing Foley's catheter, maintaining IV line, suturing. These are the skills which are common in all the specialties. So we made sure that none of these skills were repeated in across all the specialties, and then we made sure that at least we could cover as many skills we could. Of course, we could not come up or achieve everything perfect, but we were near to, you may say that we were quite close to it.
How frequent you perform this grand OSCE in a year?
Sir, no, not frequently, just once a year, that is for final exam, final prof.
Only final?
Only for final prof.
Only one time?
Only one time at the exit exam. You may say for their exit exam, final year, we conducted this Grand OSCE, and we have conducted it twice now. We conducted first in 2023 and then in 2024 also.
What is the impact of this great OSCE on the outcome?
As far as outcome is concerned, I think we should do another study on it with our house officers, and only then we can find out what was the outcome of it. We will have to do this. Thank you.
Assalamu alaikum. This is Dr. Mehreen Siyal from Ziaullah Hospital. Basically, the whole idea about this was to exclude the knowledge component which we were assessing in the theory exams as well, and the OSCEs which usually are being conducted in different institutes and in our institute as well. So we were just putting the stations. There were a lot of static stations as well, and the stations having radiographs as well. That is not that can be assessed in your clinical exams as well, in your theory exams as well. So the idea was to put the psychomotor part in the communication, purely base this OSCE on the psychomotor skills and the communication skills. So we just stuck to those stations, and those those were the performance. The student had to come and perform. He had a communication skill station, had a skill station, passing NG2, doing cervical collar, all these things. So that was purely on psychomotor and communication skills, which we cannot assess in the other component of the exams. So basically that was the idea, and that's why we sorted out all the stations from the medicine part, the pediatrics part, and then could do the grand OSCE at one time. So that was the basic idea.
So adding more to what Dr. Arsalan just said, that during the year these students...
Thank you, Bete.
Okay,
Time
thanks.
is over, more than over now.
Thank you.
Thank you very much for a nice presentation.
Thank you, Dr. Nadia, for that informative presentation. Now we are having our second contestant, Dr. Hafiza Maryam Masood. She is a senior registrar at Fazayarut Medical College. Her abstract is titled Efficacy of bupivacaine installation in the gallbladder bed in patient undergoing laparoscopic cholecystectomy for post-operative pain relief. We look forward for her valuable presentation and clinical insight. Please come.
Assalamu alaikum everyone. I am Dr. Hafiza Maryam Masood, working as Senior Registrar at Fazayarut Medical College, PF Hospital, Faisal. With heartfelt gratitude, I want to extend my sincere thanks to the Surgicon for this great opportunity to be a part of this prestigious event. The title of my study is excuse me, can somebody tell me? I need a pointer here. Yes. Is this the pointer? It's not working.
Professor Abdul Majid Chaudhary is here. I request Professor Majid Chaudhary to take the dice here, please. Professor Majid Chaudhary, our mentor, sitting behind. Please come over there.
Sorry for the delay, pointer is not working.
Pointer will come back in.
Sure, sir.
Yeah, sure.
So, before dive into the presentation, I would like you, excuse me, how does it work? It's not working. Thank you. So, go back. Sorry. So, here is the title of the presentation. The efficacy of bupivacaine instillation in gallbladder bed in patients undergoing laparoscopic cholecystectomy for post-operative pain relief. So, the scope of the presentation is introduction, objective, methodology, analysis, results, and recommendations. Nothing to be disclosed here. Before dive into the presentation, I would like you to ask a quick question. So, have you ever had a friend who just could not let go things and always holding that stuff which he or she doesn't need? Anyone? No? Yeah, it's gallbladder. except instead of emotional baggage, it holds on to cholesterol and turns it into stones. So gallstones are the most common biliary pathology and affect 10 to 15% of the population in Western society. And as a general surgeon, we all know that laparoscopic cholecystectomy is the standard treatment for the symptomatic cases. As it reduces the pain and it reduces the recovery time, but pain control is still needed and is still considerable. There are lots of researches are going on which explore the minimize the complications while enhancing patients' outcome. Various methods have been used to control the postoperative pain. Intraperitoneal local anesthetic agents, aerosolization, and intraperitoneal bupivacaine instillation is also a method to reduce the postoperative pain. And it has been a matter of debate for almost 10 years and is still undecided. There are multiple studies which showed that use of intraperitoneal local anesthesia has a significant results, and it was seen that bupivacaine is very effective in pain management. The choice of analgesic technique play a crucial role in attenuating the perioperative stress, optimizing the pain control, and enhancing the recovery. The rationale of the study is to find out the efficacy of installation of local anesthesia in gallbladder bed in patients undergoing laparoscopic cholecystectomy in terms of decrease in postoperative pain, need of postoperative analgesia, and prolonged hospital stay. The objective of this study is to compare the postoperative pain control in patients who receive bupivacaine versus the patient who did not receive bupivacaine intraperitoneal. So, after approval from the Ethical Review Committee of Pakistan Air Force Hospital, Islamabad, we started this trial, randomized controlled trial, and we made a questionnaire and took informed and written consent. And the consent form was in Urdu and English for the better understanding of the patient. So it was a randomized controlled trial at PF Hospital, Islamabad, and the duration of the study was August 2021 to February 2022. We used the WHO sample size calculator for the sample size calculation, and the sampling technique was non-probability consecutive sampling. Patients were randomly divided into two groups. The one group which received 0.5% installation of bupivacaine in gallbladder bed, and the other person, group B, group B, who did not receive. And this randomization was done by, in the presence of the surgeon, the consultant surgeon who did the laparoscopic surgery. And the installation of bupivacaine was also done by the consultant surgeon, and post-operative pain assessment was done by a trainee doctor, and all the findings were recorded in a performer. Then the pain assessment and analgesia was done by visual analog scale by a trainee doctor who was on call on that day. And the pain visual analog scale were explained to the patient before surgery for the better understanding to both groups, the group A who received bupivacaine and group B who did not receive bupivacaine. And we took 0 as no pain and 10 is maximum pain. The pain control definition was visual analog scale less than 3, which is pain controlled, and the rescue analgesia was ketorolac 30 milligram IV and nalbuphine 110 milligram IV if patient needs. So data was calculated in the form of variables and was stored and analyzed on SPSS version 20. And chi-score test was applied to compare post-operative pain relief in group A and group B patients, and the p-value of less than 0.5 was taken as significant. So in our study, the frequency of post-operative pain control was seen in 29 patients out of 33 who are in group A, and the patients who did not receive bupivacaine was 16 in group B who got pain relief. So we see the significant results. And the p-value was significant here. Here you can see the pain control. If we can see the pain control in group A patient, 87.88% patient control has pain control, while the patients who did not receive local anesthesia were only 47% of the patient got pain relief. So we stratified pain relief by the age as well. And here we can see the patient in the age group of 51 to 80 years got more pain relief. 93.33% got relief of pain after instillation of bupivacaine. While the person who are 18 to 50 years who receive bupivacaine, their pain threshold is less, and they are 83.33%. And the stratification of pain relief by gender shows obvious results. As male has more pain threshold, so we saw that 91.65% males got pain relief, and 77.78% females who got pain relief. And the patients who did not receive were quite less, 25% in female group and 56% in male groups. So bupivacaine significantly improved post-operative pain control in laparoscopic cholecystectomy. It's recommended for routine use because it's simple, it's under vision, effective because it relieves pain and improves recovery, early discharge to the home. Recommendations are implement routine use of intraperitoneal bupivacaine instillation, and we suggest that further studies with larger sample size should be suggested, as our sample size was quite small, 66. And we should explore combined techniques for enhancing the outcome. As we conclude, I want to express my deepest appreciation to my incredible team. This is our team members. Some of them are here, some are not. Thank you so much, all of you, for helping me out in this trial. Thank you.
Did you stratify the patient as difficult cholecystectomy and easy cholecystectomy? Because the patients in whom it is a difficult cholecystectomy, we do a lot of maneuvers, and that increases the patient's pain.
Sir.
And the patients who are easy lap chole, in which the procedure is, insignificantly goes on, the pain is already low.
Sir.
So if you give bupivacaine to those patients in which the cholecystectomy was easy, their pain relief would be good.
Sir. Sir, you are very right. We have a criteria, inclusion criteria and exclusion criteria. The inclusion criteria of the patients who came to us in OPD electively for symptomatic cholelithiasis. We only included those patients 18 to 80 years of age. And the diseased gallbladder, the empyema gallbladder, the gangrenous gallbladder, and the malignancy or anything like that, female patients, these are our exclusion criteria. We did not include these patients in our research.
Thank you, Maryam.
Sir.
Thank you for doing RCTs. I know it's a difficult task to do. Thank you so much for that. I have a few questions. One of them was, what was the process of randomization? And if I can ask, second question is, were the assessors who were assessing the patients, were they similar or they were different?
No, basically patients were randomized patients were randomly divided. We did not choose this is the patient, isme hum lagayenge ya nahi, randomly divided. We have a sample size 33 in each group. So we didn't randomly choose the patient, and the assessor was different. The bupivacaine was given by the surgeon who was performing the surgery. And the assessor was a trainee doctor who did not know that in this patient bupivacaine is given or not. So he was a trainee doctor, he did not know, and he did the assessment of pain after surgery.
Can I ask you a question?
Sir.
It was a good presentation.
Sir.
I'm Professor Naeem Shabir.
Sir.
You didn't mention the volume. Volume dependent. It's volume dependent, bupivacaine. How much volume do you, and was it uniform volume you used in all the patients? For example, 3 ml, 2 ml, 5 ml?
Sir.
Number 2, do you know what is the half-life of this bupivacaine?
Sir,
Intraperitoneally?
Sir, bilkul. Sir, we did...
And sorry, and the last says, did you use the pain scale
Sir.
from 0 to 10?
Sir,
Thanks.
sir, the volume was given according to body weight. It's 2 mg per kg was the dose. We did bupivacaine 0.5% bupivacaine according to weight of the patient. And what else did you ask? Sorry.
Volume in
Pain.
What is the volume? Standard volume 10 ml, 5 ml, or just?
No, according to body weight, sir. We calculate the dose according to body weight, and pain was assessed on visual analog scale, which was explained to the patient before surgery. And after that, post-operatively, we assess it. The pain scale, visual analog scale, which is 0 is no pain, 1 to 3 is mild, 4 to 6 is moderate, and 7 to 10 is maximum pain. So we assess the patient according to visual analog scale.
Can I have a question, please?
Sir.
Excellent effort, I know, but doing this research has already been done several times in several places in several institutions.
Sir.
There's a lot of confounding factors that you need to really rule out. The age groups of the patient that you are taking, we all know the younger the patient, the more the pain they have because of tense abdomen or tight abdomen. Then were the wounds infiltrated before you're going to do a laparoscopic cholecystectomy? How much of bupivacaine was used? Was it on the bed of the gallbladder, or was the whole abdominal installation that you'd used on that? And was the operating time clearly defined? Because it's been seen that bupivacaine is normally working when the operating time goes above 40 minutes of operating time. And there's a lot of confounding factors. It's an excellent effort. We need to work more on that. But you need to cut down on these before you can really make a conclusion, because your result is very significantly high. Your result is p-value is pretty high, which is not supported by the international literature that we've seen up till now. So you need to really cut down on everything before you can really decide what is true and what is not true, to at least make an international, not an international, but at least a national recommendation of how to add it onto a pain relief for a laparoscopic patients. That's just an observation, but it's an excellent effort, I should say that.
Thank you, sir. Thank you. Thank you.
Thank you.